we'll start the session. Is everything fine? Can you all hear me? Shall we start? So let's start. I welcome you all to another session of INICET PYQ Masterclass. So again, we'll be discussing a few previous year's questions, and today the questions are a little newer ones or topics which are usually not where you are not very well versed at the UG level. So let's start by discussing each question one by one. So like always, I'll read out the question and all the 4 options, and I encourage all of you to answer in the live chat box so that you all are aware of how to attempt or how to go about the questions. All right, and please mention the question number along with your answer. All right, it's my request to everyone, please mention the question number along with the answer. Good evening, HS. Okay, so starting off with question number 1, a patient with panfacial trauma underwent the following test. Identify the name of the test. Your options are A, beta 2 transferrin test, B, Jones test, C, bowstring test, D, forced duction test. So here is a image that is given. Okay, so identify the image and let me know what should be the answer out here, and then we'll discuss. Okay, I have 2 answers. Anyone else who wishes to answer? Okay. So before coming to the answer, let's see. There are certain tests that we do during our clinical examination, especially for NOE fractures. Okay, so that you can identify if there is a NOE fracture or not. So the first one is known as a bowstring test. All right, so what do we do in a bowstring test is, you keep one hand on the medial canthal tendon, okay, here where its attachment is, you grab the lateral canthal tendon and pull it laterally. All right, I want all of you to do this for yourself. So you will feel a resistance at the medial canthal tendon if it is intact. Okay, if it is not intact, if there's a NOE fracture or if it is detached from its canthal attachment, then you will feel the bone moving here at the medial canthal attachment, or you will feel loss of resistance. That is known as a bowstring test. The second one is a bimanual palpation test. Okay, so what is done in a bimanual palpation test is, I have the visuals for both of them, so I'm going to show you. Okay, so in a bimanual palpation test, you introduce a Kelly clamp or any instrument via the nostrils into the nasal cavity, and you introduce the instrument up till the nasal process here where the medial canthal attachment is, and so you have an instrument placed intranasally, you place your hand on the medial canthal tendon, so you try to move this instrument laterally or push it outwards so that you can palpate any movement. If you palpate any movement, that means there is a NOE fracture. Okay, so please look at the visuals. This one is a bowstring test, and this one is a bimanual palpation test. You can see in the bimanual palpation test, you introduce a Kelly clamp or any instrument. Okay, it should be a blunt instrument, non-traumatic instrument, up into the nasal cavity. Okay, so this is how it is done. So coming back to the question correct answer here is a bowstring test. Bowstring test is the correct answer. Okay. Now let's move on to the next question. Question number 2. What does Jaeger's test assess in eye vision? A. Farsightedness, B. Nearsightedness, C. Monocular vision, or D. Binocular vision. So let me know what would be the answer here. Answer to question number 2. So this is a little difficult question. So this is basically asking you what is a Jaeger test. Okay. So let us first see. Now there are 2-3 charts. Okay. One is known as a Jaeger's chart. Okay. And another one on your screen is known as the Snellen's chart. Alright. Now I'm sure many of you must have seen a Snellen's chart whenever you go for an eye checkup or eye examination, especially people who wear spectacles. Okay. So in Snellen's chart, you have different words mentioned in different lines and the font size is decreasing. Okay. So this Snellen's chart is placed at a distance of 6 feet from you and you are then supposed to read out this chart. So Snellen's chart is for far vision, or it is used to test distant vision. Okay, please remember, Snellen's chart is used to test distant vision at 6 feet. Similarly, there is something known as a Jaeger's chart. Now, Jaeger's chart is used to test near vision. Alright, so in Jaeger's chart, you have paragraphs. You don't have alphabets, you have paragraphs whose font size is decreasing as you go below. Okay, now this Jaeger's chart is usually used to test the near vision. So it is usually placed at a distance of 40 centimeter from the eye. Okay, which is approximately 14 to 16 feet. So this chart is basically used to test for reading glasses, if I have to tell you in very layman terms. So this chart tests near vision. This chart tests near vision. Okay, so Snellen's chart for distant vision and Jaeger's chart for near vision. So the correct answer here is nearsightedness. Nearsightedness. Now one is Jaeger's chart, one is Snellen's chart. The other one that we are supposed to know as a part of our trauma is a Hess chart, and we all know this is used to assess restriction in gaze or muscle entrapment. Okay, so please remember these 3 charts and what they are used for. Let's move on ahead to the next question. Question number 3. Which of the following is not a treatment alternative for enucleation in odontogenic keratocyst? Your options are A. Carnoy solution, B. Peripheral osteectomy, C. 5-fluorouracil local application, and D. Preoperative radiotherapy. So what would be the answer here to question number 3? Please let me know in the live chat box below. Okay, more answers. Anyone else who wishes to answer? Okay, so the question is asking, which of the following is not a treatment alternative for enucleation in OKC? Please don't get confused. Whatever has been given in the options are mostly adjuvant treatments. Okay, so they form a part of treatment of OKC along with enucleation. Okay, so they're asking you to identify which of the following does not form a part of the treatment. Okay, so you have to identify that. Now let's see one by one. Cornoid solution, yes, we all know that we use cornoid solution after we have done the enucleation in the remaining hollow bony cavity. We apply cornoid solution. Its function is chemical cauterization, so it helps in targeting satellite cysts or daughter cysts, and it helps in decreasing the recurrence. Alright, so cornoid solution is definitely used. Again, the second option, peripheral ostectomy. If you remember my classes, I've told there as well. Peripheral ostectomy can be either via curettes or with the help of surgical birth. So this is also done after enucleation to decrease the chances of recurrence. Now remains option C and option D. Out of option C and D, we can use 5-fluorouracil topical application. So it is used in the same way as cornoid solution. Once you have enucleated the entire cyst, when you are left with the hollow bony cavity, you take 5-fluorouracil on a gauze or a cotton pellet and you apply it to the hollow bony cavity or the surgical cavity in the same way as you apply your cornoid solution. You let it sit there for 3 to 5 minutes and wash it off and then start your closure. Alright, so 5-fluorouracil is also a adjuvant method. Now the advantage of 5-fluorouracil over cornoid solution is that it is less toxic and irritant to the nerve. Alright, it is less toxic and irritant to the nerve tissue. Okay, so here option D, preoperative radiotherapy does not have any role in the treatment of odontogenic keratocyst as it is not a radiosensitive pathology. Alright, it is not a radiosensitive pathology, hence preoperative radiotherapy does not have any role to play in OKC. Please remember this. Okay, so let's move ahead. Coming to question number 4, a patient presents with deviation of chin to the left side, which is painless. What would be your diagnosis based on the following radiographs? A, osteochondroma, B, right condylar fracture, C, TMJ dislocation, D, condylar hypertrophy. So what would be the answer here? Please let me know. Okay, more answers please. Everyone who's live with me right now, please try and answer. Alright, just about a month left for your exam. This is the correct time to gain confidence and rectify your mistakes in real time. No one is going to judge you, no one is going to scold you. Alright, and here most importantly, you are not losing marks for the wrong answer. Okay, let's see now. A patient presents with deviation of the chin to the left side. Okay, so the patient is having a painless deviation. There is no pain associated with the patient's condition. What would be your diagnosis based on the following radiographs? Let us see the radiographs. Okay, let's first see. This is a coronal section. Okay, I'll trace out. Okay, so if you see, this is the normal condylar outline. Okay, now I'm going to erase this. So if you trace the right condyle, okay, it has a outgrowth towards the medial side. All right, it has a mushroom-like growth on the medial side. So there is something that is growing from the condyle or arising from the condyle. Okay, now again I'm going to erase this. Okay, I'm going to zoom out further. If you see, this area is a little radiolucent, or it is less radio opaque. Okay, this is one thing that you figure out. Next one, if you see, all right, so there are two images. One is this one A and one is image B. Okay, now, and if you see, there is a, this area is darker as compared to the surrounding area. Okay, and if you see here, this area is shiny bright. All right, there is orange fluorescence. So this signifies increased tracer uptake. Right, now this image here is a SPECT scan, single positron emission computed tomography. Okay, so this is a SPECT scan. There is increased tracer uptake in the right condylar region, also known as a hot spot. Also known as a hot spot. This signifies increased metabolic activity okay, or it signifies active growth. All right, or it signifies active growth. Fine. Okay, now let's rule out osteochondroma. Yes, OMA seems like a tumor, seems like a growth. It can be one of the answers. Okay, right condylar fracture. No, this cannot be the answer. For a fracture, you will have a fracture line visible, maybe a deviation, displacement, dislocation of the condyle. Okay, it is also not TMJ dislocation, because TMJ, the condyle is within the confines of the glenoid fossa. It is not displaced. You can easily visualize it in the glenoid fossa in both the images. D is condylar hypertrophy. Yes, this can be one of the answers. So now the confusion remains between A and option D. Now to deal with this confusion, let us go into a little detail so that when you remember, when you go for your exam, anything can be asked amongst these entities, so you are well aware. Okay. So osteochondroma, it is a rare benign tumor of condyle, and as the name suggests, osteochondroma, so it is exophytic bone covered by a cap of cartilage. Alright, if you remember, I showed you the radiolucent area surrounding the radiopaque area. So, osteochondroma. Clinical features: facial asymmetry, that is deviation towards the opposite side. So the question mentioned deviation towards left side, and the radiographs had a growth in the right side. Okay, malocclusion. Okay, patient will have malocclusion. Restricted mouth opening, and your SPECT scan will show enlarged mandibular condyle unilaterally with an exophytic growth characterized by increased tracer uptake. All right, and that means the scan will show a hot spot. Okay, and the treatment is excision and TMJ reconstruction if extensively it is involved. Fine. Now, apart from this condylar hyperplasia, there are two entities which are confusing: condylar hyperplasia and condylar hypertrophy. This is essentially a postgraduate topic, but I have listed down a very few points from which you can easily identify in the exam whether it's condylar hyperplasia or condylar hypertrophy. So now coming on to the definition, condylar hyperplasia is pathologically active growth. So that means the condyle is growing actively. Okay, the condyle is growing actively, but its shape would be maintained. It won't show an exophytic growth. Condylar hypertrophy is a developmental overgrowth or enlargement of condyle. Okay, so that is pathological, this is developmental. Tracer uptake, very important. Condylar hyperplasia, since its active growth will show increased tracer uptake, and this will show no uptake. Okay, age of onset condylar hyperplasia, especially seen in growing adults, young adults, or adolescent ages. Okay, and condylar hypertrophy, basically adults, often after growth completion. Alright, so hypertrophy is prevalent after growth has completed. Clinical features: condylar hyperplasia, progressive painless facial asymmetry, chin deviation to opposite side. So the asymmetry or the deviation will keep on progressing and it will keep on getting worse from time to time. Here there is asymmetry would be there, but there would be no active progression. The patient will tell this asymmetry has been like this for so many years. Okay, please understand. Radiology, like I told you, enlarged condyle with continued activity on scans, and there is no metabolic activity on scans in hypertrophy. Hypertrophy. Treatment is high condylectomy if the growth is active, with or without orthognathic surgery depending on patient's condition. And in hypertrophy, there is usually surgical reshaping of the condyle to give it proper form and function. Okay. So now I want you all to understand the difference. Look at the images again and read the question and then decide between A and D. Good evening. Good evening. Please answer the question. Okay. Two of you have got the answers correct. Others, please answer this question after the explanation that I've given you so that we know that you all are aware. Any more answers? Okay. The correct answer here is osteochondroma. Okay. Deepa, please come back when I finish my session. Please come back and go through the explanation again. But to just tell you in short, okay, this condyle shows a bony growth which is exophytic and outwards. Okay, fine. In condylar hyperplasia or hypertrophy, you will just see a enlarged condyle. You won't see a growth that is going outside the normal morphology of the condyle. Okay, so please come back and see the explanation again. I'm erasing out all of this markings so that when you come to revise this session or revisit this question, you understand. I hope you have understood, Deepa. Okay. Coming to question number 5. During a Leaford 1 osteotomy, the patient develops sudden bradycardia while mobilizing the maxilla. What is the most likely cause of this reflex bradycardia? A. Stimulation of the fifth nerve. B. Stimulation of the sixth nerve. Stimulation of the third nerve, or stimulation of the seventh nerve. So what would be the answer here? Please answer, all of you. Quickly, I have explained a similar question in one of my previous sessions also. Yes, very good. So the correct answer is stimulation of the fifth cranial nerve, and this phenomenon is happening due to trigeminocardiac reflex or oculocardiac reflex. Okay, fine. If you want the explanation, I have explained in the previous sessions. You can go and have a look over there. Yes, very good, HS. Fifth nerve, which stimulates the vagus, which causes reflex bradycardia, and other triad. It is a triad of hypotension, bradycardia, and nausea, vomiting. All right, trigeminocardiac reflex. Very good, HS. Coming on to the next question. Yes, RITS, TCR, that is trigeminocardiac reflex. Very good. So, coming on to the next question, which syndrome is most commonly associated with mandibular ankylosis? A. Proteus syndrome, B. Klinefelter syndrome, C. Hallermann-Streiff syndrome, and D. Acrofacial dysostosis. So, this is another difficult question. Okay, please try and answer. I'll explain as well. Don't worry, even if you are not sure of the answer, just answer. So let's see. Okay, now this is okay. Nimisha, you have a doubt between C and D. Let's clear your doubt. Hallermann-Streiff syndrome. Now, amongst the given options, okay, none of the syndromes primarily show TMJ ankylosis. Okay, you once I tell you this Hallerman-Streiff syndrome, I'll explain as well. So this is also known as oculomandibular dyscephaly. Okay. So now what does this, you should also know the other name, because examiners can also ask you or give you the other name. Okay. Now let us see what are the features that are seen in this syndrome. So bilateral congenital cataracts. Okay. So the child will have, or the patient will have, cataract since birth. Okay. Bilateral microphthalmia. All right. Fine. Microphthalmia, small sized eyes. Craniofacial disproportion, that is bird like face. Alright, this entire craniofacial skeleton will be disproportionate, it won't be the normal proportions. Mandibular hypoplasia. Okay, forward displacement of the mandibular condyle disc. That means the disc or the condyle will be anteriorly placed as against its normal anatomy. Fine. High arched palate, small mouth, again forms a part of craniofacial disproportion, multiple dental anomalies, proportionate small stature. Overall stature of the patient would be small. Okay. Now, last point is very important. Specific features such as micrognathia and anterior displacement of TMJ increases the likelihood of ankylosis. Fine. So it won't be one of the primary feature, but this patient would be more prone to developing TMJ ankylosis because of certain features like micrognathia, anteriorly displaced TMJ and condyle or disc. Okay, so that is why Hallerman-Streiff syndrome. Okay, Hallerman-Streiff syndrome is the correct answer out here. Sorry. This is the correct answer. Hallerman-Streiff syndrome. Okay, I hope it is clear to everyone. So this is something please remember, and please also remember the features that are seen in Hallerman-Streiff syndrome. Okay. Coming on to next question, question number 7. A patient underwent surgical extraction of a mandibular third molar and was prescribed augmentin, diclofenac, and paracetamol thrice daily. The post-operative course was uneventful for 3 days. However, on the 4th day, he presents with redness, pain, and foul-smelling yellowish discharge from the socket. How should this condition be managed? 1. Increase the dose of augmentin to 1000 mg 3 times daily. 2. Add metronidazole 400 mg thrice daily. 3. Adopt a wait and watch policy. 4. Cut one suture to allow drainage, irrigate the socket, and place a gauze dressing. So your options are 1 only, B 1 and 3, C 1, 2 and 4, 2 2 and 4. So what would be the answer here? So this is a question which is based on clinical application, and try to remember your clinics, try to remember what you do clinically, and then answer this question. I'll explain as well, but please attempt. Okay, others? Yes, Ritz, I'm coming to your doubt. I'll just explain your doubt. Okay, let's discuss. Patient underwent a surgical extraction of mandibular third molar. Okay, and was prescribed augmentin, diclofenac, and paracetamol thrice daily. He was uneventful for 3 days. However, on the 4th day, he presents with redness, pain, foul smelling, yellowish discharge. Okay. Foul smelling, yellowish discharge from the socket. Okay. Now, very commonly, you all will mistake this with a dry socket, but it's not a dry socket. A dry socket will not have a discharge. A dry socket will have exposed bone, painful, red, extremely tender, foul smelling, yes, but it will have exposed bone but no discharge. Alright, this is the catch in the entire question. That means if there is a foul smelling yellowish discharge, this is pointing towards pus. So the patient is having post extraction infected socket. Right, the patient is having post extraction infected socket. Okay, now let us discuss one by one. Increase the dose of augmentin to 1000 milligram thrice daily. No, with you are just augmentin is just taking care of the aerobic cover. Okay, so increasing augmentin is not going to help. Okay. 2. Metronidazole 400 milligram thrice daily. Yes, because metronidazole is going to provide anaerobic cover. Alright, now anaerobic cover, usually anaerobes are responsible for post extraction infection. Okay, so you will add metronidazole 400 milligram thrice daily. Adopt a wait and watch policy. No, it will go into a space infection, which is already draining pus. There are chances that it will go into a space infection. Okay. Option 4, cut one suture, allow drainage, irrigate the socket and place a gauze dressing. Yes, you will do this. To prevent it from going into a space infection, you will open up one suture, you will give it a drainage path so that the pus has a free flow outside rather than going into a facial space. Alright, you will irrigate it nicely. You will try to give it a antiseptic, antibacterial wash, and you can place a gauze dressing for the pain. Okay. So 2 and 4. Option D is the correct answer. Okay. Is it clear? RITS and HS, why it is not a dry socket? I hope it is clear to both of you. Please let me know. In the meanwhile, we'll go on to the next question. Question 8. Which surgical technique is indicated for removal of a part of jawbone underlying a soft tissue malignancy? Option A, hemimandibulectomy. Option B, segmental mandibulectomy. C, maxillectomy. D, marginal mandibulectomy. Please answer this. In the meanwhile, I'll take the doubts. HS is saying in dry socket only analgesics and ZOE dressing. Yes, absolutely correct. In a dry socket, you can give analgesics, you can give an obtundant dressing. Okay, you can irrigate, you can give an obtendant dressing in the form of either zinc oxide dressing or algae. Okay, fine. Yes, Ritz, it's an interesting question and it really tests your clinical knowledge. So whenever you have a question like this, my advice is please read out. And the way I have picked out the keywords where I've underlined and encircled, I know you cannot do that in the exam, but just make mental notes of the keywords and try to correlate with the clinical scenario and with the theory that you have read. Okay, and then try to imagine yourself what would you do in such a clinical scenario. What needs to be done for patient care? You will arrive at your answer most of the times. Okay. Yes, others also please answer this question. Question number 8. Okay, now let's understand this question quickly. I'll draw two scenarios, okay? Right? In this one, there is just a soft tissue malignancy. Okay? Fine? And in this one, there is this soft tissue malignancy which has invaded or eroded the underlying bone. Okay, now let us see. In a soft tissue malignancy which has not invaded the underlying bone or which is not reaching the underlying bone or which is not eroding the underlying bone, from the soft tissue you will take 1.5 centimeters, and here this is air. Superiorly there is air. So if I trace this, this is how you will remove this block. Okay, now if there is underlying bony erosion, okay, or if the underlying bone is also involved, then you have to radiographically study the area or the length till where it has been involved. So if suppose this is the erosion that you can see on the radiograph, so from that eroded area you will take 1.5, 1.5 and 1.5. Okay, so you will end up removing this entire block. So this will result in a segmental mandibulectomy or a segmental resection, and when only the soft tissue is involved, it will be a marginal resection or marginal mandibulectomy. Okay, so the correct answer here is marginal mandibulectomy. Okay, please remember, in this question nowhere it's mentioned that the underlying bone is eroded or invaded or involved. Okay, coming on to the next question, question 9. Surgeon's knot is described as A, single throw in one direction, B, single throw in one direction followed by one throw in single direction, C, double throw in one direction followed by two throws in opposite direction, D, double throw in one direction followed by one throw in opposite direction. So what would be the answer to question number 9? Please let me know. Yes, others also. So let's see types of knots. Okay. A reef knot is also known as a square knot. It is a secure knot used to join two pieces of rope or cord. Alright. So what is a reef knot? You take two ends of a rope or a thread and you tie them together. Okay. Fine. That is known as a reef knot. Surgeon's knot. A surgeon's knot is a modification of the square knot. So it is used in surgical setups. Alright. So that your knot is safe and secure and it does not open up when you're suturing. Alright. So two throws in one direction followed by one throw in opposite direction. Fine. And granny's knot is formed by tying two identical half knots on top of each other. So while if some of you know stitching, or if you have ever stitched a button, so in the end when you are completing your stitching the button or stitching a cloth, in the end what do you do when you have to tie the knot? You tie 2-3 knots on top of each other, all right, so that the thread remains secure. So that is known as a granny's knot. Okay, so please keep this in mind. So a surgeon's knot is double throw in one direction followed by one throw in opposite direction. This is the correct answer. So question 10, in which of the following condition is antibiotic prophylaxis not recommended prior to invasive dental procedures according to the current AHA guidelines? A, presence of a prosthetic cardiac valve. B, mitral valve prolapse without regurgitation. C, unrepaired congenital cyanotic heart disease. D, history of infective endocarditis. So I want all of you to answer this question. I have given a table regarding this. We discussed a similar question in my last session. So please, all of you, please answer this. Question number 10. So I also want you all to note that the recent trend is that instead of directly repeating the question, INI tends to repeat topics. Okay, so be thorough with the topics. Okay, certain things like LA toxicity, prophylaxis, extraction, suturing, they have very recently made it a trend to repeat topics. So you all have to be thorough with topics rather than trying to, trying to expect repeat questions. Please expect repeat topics. Answers to question number 10, please. Okay, so the answer here is mitral valve prolapse without regurgitation. Okay, mitral valve prolapse without regurgitation. Fine. So the okay, HS, to clear your doubt, B is the correct answer. C, unrepaired congenital cyanotic heart disease. First of all, in such cases, you would try not to do an extraction. Okay. However, if it is to be done, it is to be done under prophylaxis. Okay. So, mitral valve prolapse without regurgitation. Okay. Nimisha, in prosthetic heart valves, it is a high risk case. We don't want the heart valve to get infected. So it is a sure shot indication for prophylaxis. Okay, I have given this chart in my previous session also. I have again put down this chart. We will not go into the details. I'll not read out this chart. Please take a screenshot, revise this, add it to your notes, and please try to remember the conditions under each category: high risk, moderate risk, and low risk. Okay. Please take a screenshot. I'll hold the screen for another few seconds. Please take a screenshot and add it to your notes. Coming to the next question, which type of condylar fracture has the highest risk of developing ankylosis in skeletally immature patients? A. Green stick fracture. B. All condylar fractures have an equal risk. C. Subcondylar fracture. D. Dicapitellar fracture. Very good, Nimisha. Please let me know the answer to this question, all of you. Answer to question number 11. Very good. Others? So the question says, which type of condylar fractures has the highest risk of developing ankylosis in skeletally immature patients? That means in pediatric patients. So the correct answer out here is a dicapitellar fracture. Now, dicapitellar fracture means a condylar head fracture. Alright, it is the other name for condylar head fractures. Okay, and any intracapsular condylar fracture, that means the fracture which is within the joint cavity. All right, intracapsular fractures, they are prone to developing ankylosis. Prone for ankylosis. Okay, so please remember, they may use any terminology. All intracapsular fractures are at a higher risk for developing ankylosis. Okay. Yes, dicapsular fractures are also called as intracapsular fractures. Very good, HS. Coming to the last session for today, a very easy question. Question 12. Which of the following is not appropriate for management of a simple symphysis mandibular fracture? Option A, single 2.4 mm black screw. B, double 2.4 mm black screw. C, single reconstruction plate. D, 2 mm mini plates. Okay, so which is not appropriate? Please let me know the answer here. Easy question. Others? Okay. So it is saying which is not appropriate for a simple symphysis mandibular fracture. Let's see. A single 2.4 mm lag screw. Okay. This may not be appropriate. It is saying double 2.4 mm lag screw. Yes, you can use a double 2.4 mm lag screw. Single reconstruction plate. Okay, let's keep this aside. Now D, 2 mm mini plates. Yes, we can use this. Alright. Now the confusion persists between A and C. If we go to the Champy's principles of osteosynthesis, if we revisit the Champy's lines of osteosynthesis, it always says two plates, one at the upper, one at the lower aspect. Okay, so it says two plates. Now please remember those are the principles for mini plates. Okay, so two mini plates, and anyways whenever there is a symphysis fracture, whether simple or a comminuted fracture, two or two fixation devices are a must to counteract the torsion forces. Now, when we say single reconstruction plate, if you remember last time I had showed you a reconstruction plate visual. So a reconstruction plate is 2.4 mm profile, it is thick, it is robust, alright. So a single reconstruction plate usually, and it is a load bearing fixation device. So single reconstruction plate is going to provide more stability as compared to a single lag screw. Alright, because lag screw is just a screw that you are putting it in the symphysis. Alright, so single reconstruction plate, if you have to decide between single lag screw, single reconstruction plate, single reconstruction plate is going to provide much more stability and rigidity in comparison to a single lag screw. So yes, you can put a single reconstruction plate. However, single lag screw is going to, in spite of being a rigid fixation device, it is going to make the area unstable. Alright, it is not going to counteract the torsional forces. Hence, this is the correct answer. Okay, is it understood? HS, Sujoy, Nimisha, I hope it is clear to all of you. Please let me know. Okay, again. So the confusion, I'll explain again, Sujay. the confusion remains between single lag screw and single reconstruction plate. Now, if you will visit my previous session, you would see I had shown a visual of a reconstruction plate. So a 2.4 mm reconstruction plate is a robust, heavy profile plate. Okay, it is a rigid fixation device and it is bigger in profile as compared to a mini plate. All right, and it is a load bearing fixation device. Okay, it is a load bearing fixation device. Fine. So a single reconstruction plate is going to provide more stability than a single 2.4 mm lag screw, because in lag screw we just put a screw across the fracture lines, all right, which engages both the segments. So both A and C might not be appropriate for a cis fracture, but if you have to see the one which is not at all appropriate, that is a single 2.4 mm lag screw, because a reconstruction plate will give a load bearing and it will give a hugging effect on the mandible, and it is going to counteract both the counteract the torsional forces, the twisting forces which the symphysis experiences. But a single lag screw will not be able to counteract the torsional forces here at the symphysis region. You will require 2 lag screws to counteract the torsional forces. Okay, so okay, so I hope that doubt is clear, Sujay. Okay, I have another doubt from HS. Ma'am, reconstruction plate is not only used in atrophic ridge or comminuted mandible. Yes, the primary indication is atrophic ridges and comminuted fracture. All right, the primary indication is that, but depending on the clinical scenario, it is not that it is not supposed to be used apart from these conditions. It can be used depending on the clinical scenario, depending on what is the radiographic picture, the age of the patient, comorbidities of the patient. So such things, whether there is bone loss, okay, such things also decide. The primary indications, what you are saying is absolutely correct, HS. Okay, I hope your doubt is clear, HS. Okay, very good, Sujoy. So with that, we end our session. So Friday, that is day after tomorrow, 10th, you have a constant endo session by Nitin Kararia sir, and the schedule for the next week will be updating soon. Okay, and we will soon also be announcing a predictor series. So we all your subject faculties would be discussing the important topics asked, few of the important topics asked in your previous INI exams over the past 2 to 3 years. Okay. Yes, Nimisha, I'll take your doubt. Your question is regarding INICET exam. Okay. So, Nimisha, in INI, what I have gone through the papers, I have studied the papers and, gone through your papers. There is no fixed weightage for any subject, be it medical or dental. Okay. But looking at the pattern of the last 5 years papers, the weightage is more towards your dental subjects. Okay. Now, for example, let me tell you, in May 2025, oral surgery had 12 questions. In November 24, oral surgery had 11 questions. In May 24, oral surgery had around 20 questions. So there is no fixed weightage for any of the subjects. But yes, what I have observed in INI, I have gone through the previous year's papers and I have tried to figure out the weightage for each and every subject. it differs, whether it is anatomy, physiology, biochemistry. There has been times when not even one question from physiology has been asked. So, but giving you a gross picture, the weightage is a little more towards your dental subjects, and the proportion of questions asked from medical subjects is lesser as compared to NEET, because in NEET you have equal weightage for all the subjects. Okay, so just try to focus on the important topics in from your medical subject side. Okay, because most especially the focus of the INI, when I was going through the papers, maximum weightage is from oral pathology, orthodontics, prosthodontics, and oral surgery. Okay, so don't worry about the weightage. Just try to be thorough with the important topics, or the topics that have been frequently asked in the previous years, both for medical and dental. I hope your doubt is clear, Nimisha. Also, don't worry, students. You all are doing well. All right, I see you answering correctly. Only suggestion to you all is, please read your question carefully. All right, most of the times, you just don't have to panic looking at the question. You just have to give it some time with a cool mind, read it, and try to arrive at your answer. But please, no blind guesswork. If you do not know something, all right, even if you cannot think about something, in spite of giving it a few seconds, then it is better to leave a question rather than ending up losing marks due to negative marking. No blind guesses, but even if you have read about the topic, you have heard about it from us or in your notes, I would suggest try to correlate and attempt your questions. Okay, fine. Yes, Sujoy, for NEET also we will announce something. Okay, let the INI get over, let INI get done with. So we will definitely announce something for NEET as well, and we will wait for the dates of the NEET to be announced as well. Okay. And one more thing, every Sunday from the last month, from September, we have started adding a new grant test on the app. So please go and attempt. There are a new set of questions. Okay. So please try and attempt your tests time to time. All right. And we'll be adding a lot many papers before your NEET exam. So please keep yourself in a strict schedule of attempting tests, whether your course or syllabus is complete or not complete, whether you have revised or you haven't revised. Please be in the habit of attempting tests timely. Okay, so we'll end this session here. I wish you all the very best. Keep studying, keep calm, and try to give your best. Thank you for joining in, students. Good night.